Hello and welcome everyone. Just a few housekeeping rules just before we actually start the webinar. Could I just ask that you can keep your cameras and your mic switched off during the presentations, and towards the end during the discussion time we will ask you then to obviously put your cameras back on. And also at the end of the webinar we have a QR code for feedback, which really does help us think about future events, and we would really appreciate it if you could actually complete that for us. So I'd just like to say welcome to everyone to the first of our webinar series, Colorectal Cancer Genomics from Biopsy to Personalised Care. Genomic tests for cancer patients have increased around 5-fold in the last few years, and genomics is now a key component of colorectal cancer management. Following the successful implementation of the National Lynch Syndrome project, we are all routinely using genomics for our patients. In addition, genomic test results affect decisions about the choice of treatments, such as immunotherapy or targeted treatments, and influences the dose of treatments such as 5FU. Genomic testing continues to increase rapidly, and everyone involved in bowel cancer management needs to be aware of the pathway of testing and the implications of the test results. Genomic testing takes place at the Genomics laboratory hubs for the Northwest. This is located in Manchester. The first part of this webinar will be given by Grace Berry. She's project manager for the Cheshire and Mersey Cancer Alliance, and will cover the pathway from receipt of the biopsy or resection specimen in the pathology laboratory to receipt of the genomic test result by the clinical team. The second part will be given by Dr. Michael Braun, oncologist based at the Christie Hospital in Manchester, and will cover the rationale for genomic testing. We will then finish with a discussion of some clinical scenarios where earlier genomic testing may be appropriate. So I'd now like to introduce Grace Berry, and her presentation is Improving Molecular Pathways and Cancer Turnaround Times. Thank you.
Hi everyone, I'm Grace Berry. I'm the Genomics Project Manager at Cheshire and Merseyside Cancer Alliance, and I'm going to talk you through a presentation today on one of the projects that's ongoing within the Alliance. We're going to talk through our approach, some of the findings and the next steps as well. So IMPACT stands for Improving Molecular Pathways and Cancer Turnaround Times. So just as a bit of a project overview, the IMPACT project is working across the Northwest in partnership with the Northwest Genomic Medicine Service Alliance, the Genomic Lab Hub and the 3 cancer alliances across the region. And we've mapped and audited a number of cancer pathways in order to support improvement work, to mitigate any variance we might find across the patch, and ultimately look to reduce turnaround times within the genomics pathways for patients. So I'm sure you're all aware of the complex geography across Cheshire and Merseyside with the flow of patients, samples and results. So we've had loads of work to do to be able to better understand the processes across the patch. And in doing that, we've already found some of the common issues affecting parts of the pathway. And as I say, ultimately, we want to work to support improvements where we can, both for those working within the pathways and for patients and their sample turnaround times to results. So each cancer alliance chose their own priority tumour groups based on the understood need or complexity of each pathway from discussions with stakeholders. In Cheshire and Merseyside, we focused on gynae, and that was ovarian and endometrial tumour groups only. Colorectal cancers, which was also chosen by the other cancer alliances. So we chose that as really the exemplar pathway so that we could share learning across the region. We also included breast cancers, and then we also went on to collect data from teenage young adult patients as well, but that will be used in future work, hopefully. And then we split the approach into 3 stages, and I'll go through each of these in turn. There's pathway mapping, auditing work, and then really collating a list of issues and actions throughout each encounter with system stakeholders. So starting with the pathway mapping for colorectal, I've split this over 2 pages so that you're able to see it a little bit more clearly, so bear with. And although I've produced individual pathway maps for each pathology lab, which is specific to their individual processes or systems, this is an example of a generic map for colorectal, so just so I can talk through the stages. So starting from the top, the biopsy sample is taken in theatre, and we know that biopsy is the preferred material for genomic testing over resection samples. So they're then put into formalin fixative, and the histology request form is completed with clinical details ahead of sending over to the path lab. And then depending on which trust you're at, that's either via porters internally or through hospital transport systems. And we've had feedback actually from pathologists at this stage across the board that there is need for improvement in the completeness of the request form with full clinical details, really to help direct histopathology colleagues a little bit better. Now, some sites are moving towards electronic requesting, which would be a positive step. It would help with tracking of samples or cases across the pathway, but it's not the current picture across the region. So once in pathology, the cases are cross-referenced with the clinical details that are provided. They're booked in for tracking purposes, and some sites then use a colour coding triage system, which helps with quick visualization of whether samples are urgent, non-urgent, or any specific sample types. So we've been able to share that good practice across the labs as we've gone as well. Following dissection and processing, the pathologist will interpret the H&E slide to confirm diagnosis and then complete a pathology report, which is then usually uploaded into an online system. In this case, that's Telepath for clinicians to gain access via ICE. The problem with that is, as is also the case actually when any genomic test result is available, is that the clinical teams are not notified of the report's availability. So it actually requires somebody within the clinical team to log on every day to check if there are any results available for each patient. Now, obviously, that's not an efficient use of anybody's time, but until there's a national solution which links systems together seamlessly, there is definitely a need for a local solution to this problem, because it's not just the colorectal pathway, it's all pathways that this is hampering. So then if colorectal carcinoma is diagnosed, the MMR-IHC, which is immunohistochemistry testing, is now reflexively requested by pathologists to test for Lynch syndrome. And as you'll probably be aware, there's been a national programme running since 2021 to support the implementation of optimal Lynch testing pathways. And those tests are usually requested via an internal online lab system. So if I just go to the next slide, the lighter blue boxes here just describe the steps taken depending on the MMR-IHC results. But this has been covered a lot over the last few years through the Lynch programme, so I don't want to spend on this, to be honest. But the outcomes are either that no further testing is required because Lynch syndrome is not suspected, or that the results indicate Lynch, so the patient would then be discussed at MDT and either referred to clinical genetics or be seen through the internal mainstreaming services, which should be the case in most trusts from this year. Or then lastly, that the result requires further confirmation via hypermethylation testing at the Northwest GLH. And if that's the case, the GLH request form is completed by the pathologist, sent to a shared molecular pathology email account or pigeonholes for the admin team, who then collect the blocks, give them to the lab to prepare the slides, who then send them off to the GLH via first class post or recorded delivery. And there are two ways then for the clinicians to get the genomic test results. They are either sent via email from the GLH to the oncologist directly, where that person is known, but also they're sent to the histopathology laboratory for them to incorporate into the pathology report, authorise them for upload to ICE, where the clinicians can again log on to access the results. But where the oncologist is not listed, the results will then sit solely with pathology. So it's really good practice to incorporate and authorise those results as soon as possible within pathology, so the clinical teams can have access to, in case they aren't emailed directly from the GLH. And I'll circle back to this later on when I'm touching upon the kind of improvement potential across the region. So that's the reflex pathway for newly diagnosed primary colorectal carcinomas. Going to the orange box on the left-hand side, if the patient presents with metastatic disease, then the MDT will then decide which molecular test to be requested. And that's usually KRAS, MRAS, or BRAF. NTRK fusions are occasionally requested, I think, if the patient has progressed, but that was more rare. So whichever molecular test is requested, the GLH forms are again completed by the pathologist, usually noting the clinical oncologist who should receive the results. And similarly to the MLH1 hypermethylation we discussed earlier, the request is emailed to the generic molecular path email account for the admin team, who then collect the blocks, pass them to the lab for sample prep, and the process just repeats itself as before. So that, in a nutshell, is the basic genomic pathway. And these are just a few examples of the issues or barriers that were reported across the pathways and trusts. They're split into audiences, so pathology, clinical teams, and system-wide. Obviously, this isn't an exhaustive list. I just wanted to pick out a few examples to highlight. So it was reported that molecular requests were often emailed to one individual person rather than the shared molecular pathology account. Now, obviously, that creates a single point of failure if that individual is on leave. So that's something to be aware of to ensure that you know the process within your trust and are requesting in the appropriate way. Some molecular tests came through as emails to pathology requesting genomics on X, Y, or Z patient. Clearly, there's need to have more specificity in those cases. So perhaps a degree of education on which tests would be done in which circumstances, or perhaps just the standardisation of requesting would be beneficial within trusts internally. And all of this will form part of the discussions as we continue our evaluation phase of this project. So the second one down, there is no clear, efficient pathway for the communication of results to oncologists. There are inconsistencies of how the results are presented, whether that's at MDT or if the results are chased when the patient's due into clinic. And we've talked through some of those issues earlier, but just to make you aware, there is a national plan to improve the IT interoperability around results. That'll be years off now. So, in the meantime, the Northwest GLH are trialling a portal in a couple of sites through which tests will be requested and results will be able to be accessed. It'll be a lot easier to track cases through the whole pathway then as well. So we'll keep updated on that. And then thirdly, there was one site, just as one example, there was a site who had an embargo on first-class postage across the trust. And so second-class post was routinely used to send slides to the GLH. Now, obviously, that delays the time to results. So we've worked with that trust, who now send their molecular samples first class. I just wanted to pull this out as a small example of a change in the pathway that can save some time overall. It's these incremental, smaller improvements that we're looking at, as well as the bigger picture improvements as well. And as mentioned earlier, there is a need for improvement in the amount of clinical details provided to pathology. And again, this will form part of the discussions as we continue the evaluation of this project. There are some trusts looking into electronic requesting, I think I mentioned earlier, which may improve things, especially with those kind of mismatching details on forms. But there may be some IG issues to overcome first, especially in those off-site trusts. So this is the audit data. In total, we received data relating to 406 samples across 4 pathways, and you can see the split there. So Warrington and Halton were unable to provide audit data last year due to the significant capacity issues that they'd faced, but they've now had a shift in teams, and it's fantastic that they're now able to pull that data together for us. That should be with me by the end of this month, by the end of April, which will really then add to the regional picture and ensure we've got equity across Cheshire and Merseyside with the potential for these improvements that can be made. So that's brilliant. And this is the turnaround time data for cellular pathology on the left-hand side and genomic testing on the right. It's split by tumour group, and really just to show the significant variation seen across the region. And I'm just sharing regional data today rather than the trust-specific details that have been included in the evaluation reports for each path lab. So the cellular pathology turnaround time is the time from when the samples arrived in the path lab to the time the diagnostic report was completed. And you can see that the distribution of cell path turnaround times on the left was similar across breast, colorectal and gynae samples, with the vast majority of samples having turnaround times of less than 20 days. The genomic testing turnaround time is the time from the genomic test being requested to the time that the result was then made available to the clinical teams. And that's the chart on the right. So turnaround times varied across tumour groups, with gynae, as you can see, having the widest distribution. 60% of colorectal cancer cases were turned around in between 20 to 30 days, with only 12% of cases taking less than 20 days. So there's clear room for improvement across the board. The National Genomic Test Directory specifies which genomic tests are commissioned by NHS in England, the technology by which they're available, and the patients who will be eligible to access a test. So this is just a little snippet of the Cancer Test Directory for colorectal cancers. And I thought I'd just go through a few of these and if and when they tend to be used. So regionally, the pathology network agreed that the initial test for Lynch syndrome would be best done via local immunohistochemistry testing, more so for the efficiency of results than anything else, rather than the microsatellite instability, the MSI testing that you can see is available on the National Test Directory. A further test for cases suggestive of Lynch syndrome is the MLH1 promoter hypermethylation, so test 1.5 and 1.5 here, and that's sent to the GLH4 testing in those circumstances. NTREC testing was reportedly more rarely requested, as I mentioned earlier, and that tended to be in the palliative setting. And then you've got DPYD hotspot testing, and that's requested reflexively if the patient's due to start a fluoropyrimidine type chemotherapy to prevent life-threatening toxicities. And then finally, the multi-target NGS panel for KRAS, NRAS or BRAF is used in the metastatic setting. So there is some potential for improvement in the patient pathway here and turnaround times to results. If a patient is known to have metastatic disease and is a candidate for chemotherapy, the request for KRAS, NRAS or BRAF could potentially be made on the initial histopathology request form, or reflexed from histopathology where the information is communicated between the clinical team and pathology teams, rather than waiting until further down the line when the MDT discussions take place. But the IMPACT project will continue to have these types of conversations with pathology and clinical teams to assess any potential barriers to this and share in time any recommended changes in practice. We're very much still in the evaluation phase. So this chart just shows the time taken from when the genomic test results were received by the pathology lab to when they were integrated into the pathology report to ultimately be made available to clinicians to access. In most cases, that was via ICE. And you can see there's a wide distribution, but we've already talked about how the results are distributed from the GLH and the issues that clinicians can face in accessing those, as well as the potential for some of those issues to be overcome with the GLH portal and future plans for system interoperability improvement. So I'm not gonna dwell on this one. I'll move on. As part of the evaluation phase of this project, I've written a report for each pathology lab, which details each tumour group process map, as well as all of the audit data, both for the region as well as trust-specific data. And I've also pulled together some recommendations based on those results. And the aim is that, to ensure that these reports don't just sit on people's desks, but really act as catalysts for conversation to support improvements across the pathway, linking together the clinical and the pathology teams. So I've just pulled out a few examples here. I won't talk to them all, but I'm happy to share these slides. So if each case reported the best block to use for genomic testing with neoplastic cell content as standard during that initial diagnostic workup phase, then the genomic sample preparation time would be reduced, with less steps to have to find the blocks or the slides again for the pathologist to reassess them for tumour content just for that genomic test. And similarly, it would positively impact on the potential change in roles required for some of those steps to free up consultant time. Standardisation of both genomic test requesting as well as report writing with the consistency of terminology really across sites will be beneficial for clinical teams, because they're the ones who have to interpret the reports, especially with the advent of digital pathology where there could be cross-site reporting too. As I've already mentioned, considering reflex testing within the metastatic setting could contribute to improved turnaround times to results, but we would need to ensure that other parts of the pathway don't come under too much strain. So far, the focus of this project has really been on the pathology pathways, but these are a few of the clinical team recommendations that came from conversations with teams during the process mapping phase of the work. Again, these aren't exhaustive. There's loads more work to do with clinical teams to understand more of the barriers and the potential improvements that can be made, but just to list a few, making sure that there is sufficient clinical information provided on pathology request forms was up there. Standardising those request forms and ensuring that they're used rather than emails just asking for genomics on XYZ sample, because that just further slows down the request, to be honest, because clarity then needs to be sought. Ensuring that the medical oncologist is named on any genomic test request so that the results can be sent from the GLH directly to that oncologist. And really just improving the links between clinical and histopathology teams, making the communication as efficient as possible as genomic test requests only increase will just benefit the patient pathway and reduce turnaround times ultimately. And then finally, some of the system-wide recommendations that we're aware of. The need for genomic education across the board is evident. The Northwest GMSA completed a project last year called the Training Needs Analysis Project, TNA, which through questionnaire and interview collated across from colleagues across the Northwest, worked to really identify gaps in education and training for all workforce groups concerning genomics and the application for genomic testing within these cancer pathways. So this is the first webinar that we've pulled together, which we hope will provide really useful information. We're keen to hear your feedback following the webinar so we can make sure these are really valuable resources that are actually of benefit to you all. IT interoperability improvements we've already discussed, and tumour-specific clinical quality groups or pathology boards should work really to establish optimal testing pathways, which will be informed, no doubt, by the NHS England Genomics unit in the coming months. And that's all from me.
Thank you, Grace. Wonderful presentation. I'd like now to introduce Dr. Michael Braun. His presentation is Genomic Testing for Colorectal Cancer.
Hi everyone, I'm Grace Berry. I'm the Genomics project.
Followed by the impact of genomic testing. Thank you.
So thank you for this opportunity to speak today in this seminar. So I'm going to be discussing genomic testing for colorectal cancer. My name is Mike Brown. I'm a consultant medical oncologist at the Christie Hospital. So the background is that for many years there's been some genomic testing performed initially within clinical genetics and then latterly in oncology. But over the years, the role of genomic testing has increased markedly. And now the implications, particularly in colorectal cancer, are that genomics can impact on screening for patients in terms of Lynch syndrome, also decisions regarding extent of surgery, particularly for Lynch syndrome patients. But also importantly, now is starting to impact on treatment decisions in terms of preoperative treatment, palliative treatments, and dosages of treatments that can have implications on patient discussions at MDT meetings and what decisions are made for patients' treatment overall. So it's important that the whole MDT has an awareness of the importance of genomic testing. It's also fair to say that genomic testing is developing rapidly, and the tests that we're using now, it's likely that we'll be introducing new and additional tests over the next few years. So the impacts of genomic testing are likely to increase. So in terms of what genetic testing is available, there is a national test directory which NHS England produce and is available via this website, which lists approved tests and indications for the testing. This is an excerpt from that test directory, which is specific for colorectal cancer. You can see this is quite a busy slide, and it's trying to list all the different genes, but also the different techniques that you test those genes, so but also people within the lab who are trying to ensure the testing is done to the correct standard. I'll try and pick out the main ones of interest clinically over the next few slides. So the first area we're going to look at is mismatch repair status. This is key in terms of screening for Lynch syndrome, and we know that approximately 10 to 15% of all colorectal cancers are mismatch repair deficient, with approximately 4% of patients having Lynch syndrome after subsequent testing. And over the last 6 to 7 years, there's been a drive following NICE guidance to have routine MMR testing of all colorectal cancer patients at diagnosis as a way of screening for Lynch syndrome. But as described here, we know that there's a significant additional proportion of patients who do not have Lynch syndrome, but mismatch repair deficiency is a feature of their tumour. So when we start looking at how mismatch repair deficiency is now impacting on treatment decisions, a good example is data that's come from the trial. So this was a study in colon cancer patients with locally advanced tumours, where the standard treatment would be surgery followed by post-operative chemotherapy. And the trial attempted to look at patients having a 6-week period of preoperative chemotherapy prior to their surgery. So the main question the study was asking was whether neoadjuvant chemotherapy, so preoperative chemotherapy, helped improve cure rates. And the answer from the study overall was that yes, it did, but interestingly not in mismatch repair deficient patients. When analysis was done of mismatch repair status in the trial, it was seen that just over 20% of these locally advanced tumours had deficient MMR status. Pathologists blinded to what treatment the patient received looked at the degree of response using accepted response grading criteria. And as is shown in this panel, when you look on the far right-hand side at the deficient MMR tumours, which are at the blue columns, had a significantly higher rate of no regression seen with preoperative chemotherapy. So approximately 70% of patients not responding, compared with just under 30% of patients who had chemotherapy. Importantly then, when it was assessed in terms of survival outcomes, patients with deficient MMR also had no difference in their ultimate survival with preoperative treatment, compared with patients who have retained expression of mismatch repair proteins, where a difference in response to treatment was seen, and in terms of longer term survival. So we've got evidence that our standard chemotherapies may be less effective in MMR deficient tumours from the Foxtrot study and also from some other trials. One type of treatment that does seem to be very, very effective in MMR deficient tumours is immunotherapy, and this is a relatively new treatment. It's been around now for about a decade and is being used in a range of different tumour types. But deficient MMR tumours appear to be one of the types of cancer which is most sensitive. Our evidence for benefit of immunotherapy initially comes from a trial called Keynote 177. So this trial took patients with MMR deficient tumours, they were all colorectal cancers, and patients had either standard chemotherapy or a 2-year course of an immunotherapy drug called pembrolizumab. The main endpoints of the trial were looking at progression-free survival, so how long the patient remains without worsening of the cancer, and overall survival. This figure shows that patients receiving pembrolizumab, so the immunotherapy drug, overall had double the length of time until cancer progressed, so 16.5 months compared with 8.2 months for those receiving standard chemotherapy. You can note that in the first 3 to 4 months after commencing treatment, chemotherapy is slightly better than immunotherapy, but then there's approximately 60% of patients who benefit from immunotherapy, and as is shown on the next slide, a large proportion of these patients who have had initial response remain without progression in the long run. You can see a dashed line at the 2-year point when patients complete the course of immunotherapy treatment, and beyond that you can see a longer term plateau with approximately 70% of patients not having disease progression identified at any point so far. So this is really a game-changing treatment for patients who previously would have had poor outcomes with our standard chemotherapies. In terms of treatment for operable cancers, there's increasing evidence from small studies, and I've listed 2 main ones here from patients with colon cancer, but also rectal cancer. And there are now multiple ongoing trials looking at whether immunotherapy treatment preoperatively is helpful for patients with deficient MMR tumours. This is the first trial, the NICHE 2 study, which looked at a 5-week course of immunotherapy given prior to surgery using 2 different immunotherapy drugs. And this was performed in the Netherlands. The patients generally had very locally advanced tumours, so a high proportion having T4 cancers and patients who are heavily node positive. These figures show the significant responses that were seen. So 99% of patients had a pathological response. 95% of patients had a major response, so there was less than 10% viable cancer left at the time of surgery. And 67% of patients had no viable tumour left at the time of resection, despite this being a very short period of preoperative treatment. So again, reaffirming that these tumours appear to be exquisitely sensitive to immunotherapy treatment. The rectal trial is quite a small study and was aiming to give 6 months of immunotherapy treatment with a different immunotherapy drug to that which was used in the NICHE trial. Depending on response to treatment, patients would go on either to have surveillance, or if there was residual tumour, have radiotherapy or surgery as required. Initial results from the first 14 patients included in this study showed that all patients went on to have a complete clinical response based on MR scan and clinical examination. And to date, with further follow-up, additional patients have also been confirmed to have complete responses, and no patients to date have progressed following completion of treatment. Again, re-demonstrating the benefits of immunotherapy for this patient group. So in summary, for MMR deficient colorectal cancers, it's vital that we do MMR testing for our patients. The results, as we've described so far, enable us to screen for Lynch syndrome and then expand that testing to look at within families. And from an oncological and surgical point of view, the presence of MMR deficiency opens up the potential to give patients immunotherapy currently in the palliative situation to try and control disease. But it's likely, given the results of these small studies I've shown already, that immunotherapy will continue, the immunotherapy's role will continue to expand and be used in earlier stage disease, potentially as a definitive treatment. Thank you. So we'll now move on to the second part of the discussion about the impacts of genomic testing. So this is now really focusing on the impacts of genomic testing with systemic treatment. The main areas I've highlighted here. So there's germline testing, which currently is limited to looking at a specific gene called DPYD, and I'll go into the implications of that over the next few slides. And then testing for sporadic abnormalities, so abnormalities which have just occurred within the tumour cells. And the key ones to know about really are RAS mutations and BRAF mutations, which again, I'll go through on some of the following slides. So what is DPD? So DPD is an enzyme which clears from the body a drug called 5-FU, and 5-FU is the most commonly prescribed chemotherapy for colorectal cancer, and it pretty much will be given to all patients with bowel cancer who need chemotherapy, either in post-operative or pre-operative situation, or as controlling chemotherapy for patients with advanced disease. This protein DPD is coded for by an enzyme called DPYD. So the terminology can be slightly confusing. What the figure on the slide is trying to demonstrate is that of 5-FU, which is given to patients, around about 80% is eliminated from the body by the DPD enzyme without having any anti-cancer effects. And this is a very rapid process, and we'd expect that the 5-FU drug, when it's given as an infusion, will only stick around in the body for about an hour before it's all removed. And then there's approximately 20% of the 5-FU which goes on through a number of different steps to be converted into drugs which can have an effect on the cancer cells. What we see with patients with an abnormality in this DPYD gene is that it results in a DPD protein which is less effective or completely ineffective at removing the 5-FU chemotherapy from the body, and this can result in a higher proportion or all of the administered 5-FU being converted into drugs that can cause anti-cancer effects, and that can then result in very severe toxicity from a patient's viewpoint. This schematic is trying to demonstrate that further. So the normal gene with 5-FU being cleared and tolerable toxicity, and then patients with deficiency where a very high proportion of 5-FU is converted into anti-cancer drugs, and the patient can have severe toxicity. Our data from assessing patients at the Christie shows that approximately 7% of patients in Greater Manchester have one mutation in the two genes, so are heterozygous for DPYD. And then approximately one patient in every 4,000 to 5,000 will have two defective copies. These patients are expected to have no functioning DPD activity. So it's these patients that we're trying to identify by screening patients for DPYD mutations, so that we can try and tailor the dose of chemotherapy appropriately and reduce the risk of severe toxicity. So there was a statement by NHS England in November 2020 requiring all patients to have DPYD testing prior to commencing treatment with 5-FU or 5-fluorouracil, as it's also called, or a drug which is converted into the body, converted in the body into 5-FU called capecitabine. And there are 4 gene variants, so mutations, which have been significantly associated with severe side effects from these drugs, and they're listed below. This is an example of one of the reports that we receive. So you can see with this report, it says that there's no reduced functional variant detected, and it shows that the 4 variants recommended by NHS England have been assessed, and it comments that a standard dosing strategy can be used, so the clinician can use the normal doses which are recommended for these drugs. Our second example is a patient where it's been identified that they do have a variant in the DPYD gene, and you can see that then that variant is described, and there's a statement in bold describing that the patient would be expected to have a decreased functioning variant and would be an intermediate metabolizer. So they won't have lost all of their ability to clear the 5-FU drug, but it will be impaired. And then at the bottom, you can see that there are some recommendations to reduce the dose of treatment so that the patient would be more likely to tolerate treatment, or an alternative chemotherapy can be considered if that is clinically appropriate. So as this is a germline test, the status won't change, so it only needs testing on one occasion prior to having 5-FU or capecitabine treatment commenced. The variants described predict a significant proportion of the patients who would go on to develop severe toxicity quickly after commencing treatment, but not all patients. And so when counselling patients, we have to be careful that we describe that it's trying to identify patients at higher risk, but does a negative result showing no mutations unfortunately doesn't exclude the chance of severe side effects. Most of the data that has demonstrated the importance of DPYD testing comes from Caucasian populations, and one of the areas of research is to do more assessments in non-Caucasian populations to see which genes are relevant in those populations. So we have to remember this when we're seeing non-Caucasian patients, just in terms of potential limitations of the testing. So then thinking about the sporadic changes, as I've mentioned, the most important are mutations in genes called RAS. There's 2 specific genes that we look at. There's KRAS and NRAS, and also a gene called BRAF. The figure here shows a cancer cell with a surface receptor, and then you can see that there is a pathway, and at the top of this pathway is the RAS gene, and then the second one down is the RAF or BRAF gene. So these genes and proteins are in the same pathway, and activation of this pathway is associated with cell growth, proliferation of cells, and survival of cells. So it's advantageous for tumours for this pathway to be activated. Mutations in these genes can result in higher proportion of tumours growing and surviving. In colorectal cancer, we see approximately half of patients will have mutations in either the KRAS or the NRAS gene, and approximately 10% of patients will have mutations in the BRAF gene. The most common and important mutation in BRAF gene is this specific mutation called BRAF V600E. This currently would be considered one of the mutations associated with a very poor prognosis for bowel cancer patients in the advanced disease setting. In terms of clinical features, we see there is an association with mismatch repair deficiency. So approximately a third of these patients have MMR deficiency, and we'll come back to discuss that again in a few slides. It's much more common in the right colon than the left colon or rectum. And there's an increased incidence of peritoneal metastases and a slightly increased incidence in females compared with males, comparing patients who have mutation, this specific mutation versus no mutation. As mentioned, this is generally a poor prognosis group, unfortunately, with a survival from diagnosis of 10 to 14 months in most studies. And the kind of real feature of these patients is, unfortunately, that they progress very quickly on treatment, but then also after failure of initial treatment. This trial is the Beacon trial, which was an international study and looked to compare standard chemotherapy with two different options of treatment which do not contain chemotherapy drugs. So these are combinations of targeted agents aiming to see if this BRAF mutation, which is activating this important pathway in colorectal cancer, can be turned off in the cancer cells, and whether that approach of using a combination of targeted treatments may be better than standard chemotherapy. This is the overall survival curve of the study. The trial was performed in patients who had failed at least 2 or 3 different chemotherapies. The grey line is patients receiving standard chemotherapy, and the red and the blue lines are patients receiving either 2 or 3 drug targeted treatments. And you can see that there was no real difference between those two approaches, but both of those targeted treatment approaches were significantly better than our standard chemotherapy, with patients living more than 3 months with these new treatment options compared with standard chemotherapy. As mentioned, there is a higher proportion of BRAF V600 mutations in patients with MMR deficiency. And those of you aware of the pathways for MMR and Lynch screening will know that BRAF mutation testing is one of the tests which is performed in patients who MLH1 or PMS2 loss, because generally BRAF mutation, if it's present, would mean that the patient is unlikely to have Lynch syndrome, and it's much more likely that they have a sporadic loss of MMR expression. In terms of RAS mutations, as I've said, we check for mutations in 2 different genes, and compared with BRAF, where it's really one mutation we're interested in, KRAS and NRAS testing covers 11 different mutations across those genes currently. This figure or this table shows data from the 2 key trials using targeted agents combined with chemotherapy versus chemotherapy alone, and in patients who had no mutations in these genes, so patients described as being wild type. In both these studies, there was an 8-month improvement in survival if patients had the additional targeted agent compared with having chemotherapy alone. So substantial improvements in life expectancy. And this is the real reason why we look to ensure that this testing is performed and patients have the option of going on to receive this more effective treatment. So in terms of assessing for mutations in the UK, as I've described, if patients have no mutations or wild type, they can have a combination of chemotherapy with a specific EGFR targeted drug. So there's 2 of these drugs, cetuximab and panitumumab. And patients can only in the UK access those drugs in the first-line treatment setting. In terms of patients who have mutations, that these patients would typically go forward with standard chemotherapy alone. RAS mutations, as compared with the BRAF gene, have proved more difficult to try and develop drugs that would target these mutations. And as described, there are multiple different mutations which appear to be important. Nevertheless, some recent trials have shown potential benefits for drugs which specifically inhibit the specific RAS mutations, and it's likely that some of these drugs will come into clinical use over the next few years. One of the final abnormalities to mention is a rare abnormality, which are fusions of the NTRK genes, and these are really quite rare in colorectal cancer. But this is an interesting area as a drug is specifically available and approved by NICE across all tumor types if these NTRK fusion identified. Despite testing multiple patients in the Northwest, unfortunately, we've so far not identified any patients who are suitable for this specific therapy. We do see from the clinical data, which is now becoming available, that there's a higher proportion of these tumours which are MMR deficient, and these mutations also don't tend to occur if a patient has RAS or BRAF mutations present. So we're increasingly able to focus testing on patients without RAS and BRAF mutations, and particularly patients with MMR deficiency, where it may be that we're much more likely to see these mutations. So in conclusion, hopefully I've demonstrated to you that genomic testing plays a key role now in the management of patients with colorectal cancer, and certainly anybody having chemotherapy will have some form of genomic testing performed, with DPYD testing, and for patients with advanced disease, testing of RAS and BRAF mutations, which are key in terms of determining patients' treatment options. New tests are being added periodically. So again, this is not a situation where there is a fixed testing panel that is not likely to change. We are seeing changes with new targets and new indications being added every few years. So it's an important area to keep abreast of. Thank you very much.
Well, thank you, Michael. Very interesting presentations. I would now like to bring back Grace, together with James Wingfield. He's a cellular pathology manager at Liverpool Clinical Laboratories, for a discussion on potential pathology pathway improvements. Thank you.
So hi James, I'm joined by James Wingfield, who is the Cellular Pathology Service Manager for Liverpool Clinical Laboratories. And James has been a great support with all of the cross-pathology projects we've worked on at the Alliance. So thank you, James, and welcome. Following on from the IMPACT presentation, I just wanted to have a little discussion with you about some of the potential future improvements that can be made within the pathology pathways. So I've just got a few questions, if you don't mind.
Sure.
So firstly, do you think it'd be beneficial to bring in the reflex testing in the metastatic setting for colorectal cancers? So be that KRAS, NRAS, BRAF, and what effect do you think it would have on the pathology labs, or what barriers do you think that there might be?
Okay, so currently within colorectal cancer, most of the sequencing requests are triggered via MDT. So that's after the patient's been diagnosed with metastatic disease. So implementing a reflex pathway within pathology based on staging could certainly avoid delays and ensure timely access for patients to ensure that they're eligible for systemic therapies. But I think that there's many different facets that need to be considered when you're looking at a pathway such as this, and need to assess the impact on patient management, patient outcomes, the impact on pathology, the GLH, and also I guess the cost to the NHS as well. From a pathology perspective, I think it's unlikely that reflex testing in this specific instance is going to drastically increase patient numbers. So it's probably something that we can accommodate within region, but we'd obviously want to model that impact before we implemented any reflex pathway. And certainly the introduction of the cellular pathology genomic centres as well, and the additional resource that will be coming in with the introduction of this program should help to cover any of the resource gaps that might be present currently. But I think I've completely lost myself there. Yeah, so what I was going to say is that I think the implementation of any reflex testing should be a conversation between pathology, oncology, GLH, NHS England and commissioners, and then ultimately also NICE as well. And if it's deemed that there's a tangible patient benefit and that the health economics all stack up as well, then the NICE guidelines should be changed, and we should be implementing reflex testing for patients in this setting, definitely.
Yeah. So I think those are the conversations that we'll take forward as Cancer Alliance, and feedback through any kind of CQG element to see how we can make improvements in those circumstances. Thank you, James. Secondly, so we know that the variation in pre-GLH sample processing and preparation could contribute to possible failure rates at the GLH. So we also know that the genomic sample prep should take place on DNA clean equipment. But I'm not sure necessarily that that's standardised across Cheshire and Merseyside. Could you talk us through what's considered within LCL genomic sample prep, and how we as a region should look to improve?
Yeah, certainly. So there are a number of things that need to be considered from a cell path perspective in preparing tissue for genomic analysis. And by no means do I think that LCL is perfect. I think there's always room to improve. But I think if we break it down, there are a number of different factors. So firstly, it would be the pre-analytic factors. So some of these things that are out of our control, and these are things like cold ischemic time within theatre, but some of them are more within our control. So these are things like time to specimen being placed in formalin. For colorectal samples in particular, when they come down, they are a closed organ. They need to be opened, they need to be cleaned, and they need to then be have that lumen and tumour exposed to formalin as soon as possible. And we know that we need to fix tissue to prevent autolysis and putrefaction. You know, that's been standard within histopathology for many years, but also that's important for the preservation of nucleic acids. And then equally, we need to ensure that we're not overfixing tissue as well, because we know that overfixation with formalin also impacts on the quality of DNA and DNA sequencing. So it's important that we we start to look at controlling for the time in formalin, fixation time, and also the time for these organs to have exposure to formalin, ensuring that that's occurring as soon as possible after surgery. We then need to look at our tissue processing methods and ensuring that our dehydration clearing and infiltration with paraffin wax is optimal, and that we're ensuring that tissue samples being placed in cassettes aren't too large for the processing run that they're being placed on. And I think this is still a challenge that many laboratories will be familiar with, and still something that I'm sure that we can all improve on. I think after the processing, the tissue is fairly stable. It's as stable as it's going to be, in the block form. However, when we're presenting tissue sections, stained hematoxylation sections to the pathologists, we need to ensure that our pathologist colleagues are selecting the best block based on the H&E stain for genomic analysis, and this needs to include or ensure that we've got a good tumor content, tumor nuclei content, a high tumor content percentage as well, so that we're not choosing a section that has a high number of infiltrating lymphocytes or fibroblasts or surrounding tissue nuclei, which could dilute that tumor sample, and also that we're choosing a section that has low necrosis. And if those factors are not able to be optimized or optimal within an entire tissue section, that the pathologist is actually marking up a section so that it can be macro dissected to increase that tumor content within the tissue that's sampled for genomic analysis. I think then the other thing that we have at LCL, which I appreciate is perhaps not necessarily going to be able to be replicated across the region, is a dedicated team for the preparation of genomic friendly tissue. And we do this within our molecular pathology service. They provide genomic tests as well as preparing tissue for genomic analyses. So this has enabled us to ensure that we've got a small team of staff who are regularly handling these samples and have the right training and knowledge to prepare the tissue samples. We've also then got dedicated workstations where these samples are prepared. So these are microtomes that are not within the routine histology laboratory. They're in a different location. It enables us to keep the workstation clean and also clean the microtome with nucleases between each patient sample to ensure that we're not cross-contaminating samples as we're preparing them.
I didn't realise how many methods there were from the very beginning of the pathway when the samples getting formalin fixed. I'm obviously not an expert in the area, but that's really interesting. So there's so many optimizations that we can make to make incremental improvements. Okay, and then finally, probably the most tricky question: if you could change or improve one thing, what would it be?
So I think, like the whole of the NHS, we're struggling with capacity at the moment to meet demand. And I think within cellular pathology, this is particularly pertinent. Since the pandemic, up and down the country, we've seen increases of around 30% on pre-pandemic levels of activity. And in most circumstances, we haven't had an increase in staff, substantive staff, to cope with this increase in demand. So I think if we're being ambitious and wanting to meet all of the, not only our own turnaround times, but also, I guess, the ambitions of the sort of national pathways that have recently been discussed and agreed around sort of time from biopsy or procedure through to a fully profiled result. We really need additional resource, substantive resource, to be invested in within cellular pathology services.
Yeah, absolutely. And that came up time and time again in the conversations through the IMPACT project. So I'm sure that will be echoed across the region. Thank you, James. That's really given us some food for thought. And I'm sure, there'll be a few follow-on questions or comments when the webinar does go live. So thank you very much again.
Thank you.
So thank you again, Grace and James. Wonderful discussion. So I would now like to invite back all of our fabulous speakers, but I'd also like to bring back in Dr. Jim Hill, a consultant general colorectal surgeon, for our live discussions and Q&A. So you've more than welcome everybody now to put your cameras back on. If you've any questions, you can pop them in the chat or put your hand up. All right, thank you.
Thank you. Right. So I've just got three quick case presentations. They're one slide each, and then there are a couple of questions. So one of the things we've emphasized during the webinar is whether we should be trying to get earlier genomic analysis rather than waiting for the MDT and then requesting them. So this really is for you, Mike. We've got a woman presenting at the MDT. She's in her mid-40s. She's got a right-sided colon cancer. Resection is planned, and she's got liver metastases, which are not proven histologically, but definitely present radiologically. So I guess the two questions is: would we always want genomics here, and if so, should we be getting KRAS, NRAS, BRAF at the very latest with the resection specimen and requesting the genomic analysis when we send off the resected tumor?
Yeah, thanks, Jim. So in somebody who we know has got distant metastatic disease, and that I guess there's uncertainty here whether she's going to have potentially downstageable disease to consider resection later, but she's got advanced disease, so she would be a candidate to get her genomics assessed either on the initial biopsy or from resection if she was going straight to resection, just so we got those results at the earliest opportunity to inform what chemotherapy we look to give. And obviously, as we discussed earlier, also hopefully you know her MMR or MSI as well, so that could be put into the mix about whether immunotherapy was an option.
And I think that most, obviously I'm not practicing anymore, but I think, when it was, most of the surgeons, clinical teams weren't aware of the forms that needed to be filled in. And I think one of the things that we can certainly do is circulate around the forms that do need to be completed.
Yeah, and they're available on the GLH website, and kind of Helen Schlecht and the team there are very active in terms of sort of updating them as required. And they're pretty straightforward forms, but it's just kind of navigating to find the correct one for your tumour site.
And making sure that we put the relevant consultants and oncologist names on it. And Grace's audit showed that we're waiting around 20 to 30 days for the genomic test turnaround. So if there's a bit of a wait for the MDT discussion, we're waiting an additional 20 to 30 days to get that result. So I'm sure that would improve the ability to make decisions, oncological decisions by the oncology teams.
Yeah, exactly. I think this is an issue that is probably faced by everybody doing this across the country, and it is something we've looked at in kind of Greater Manchester as well. So we made some changes, and the sort of GLH introduced some changes from the 1st of January, where rather than sending the request directly to them, we send the request to the histology lab, and we're starting to get results of some audit data about that change, and that seems to be, I know my colleague in Wigan has audited it, and that seems to have knocked off a week in terms of the wait to get the test results. And there's lots of other things that we've done to try and mean that we're getting those requests off as early as possible, just so that then patients are having those genomic results coming back either before treatment starting or as soon as possible after starting, so that we're able to institute any changes as quickly as possible.
And again, you mentioned that we can do this on the biopsy. Do you find that most of the time you can get reliable genomic information from biopsy? Say if a patient with the right colon cancer is not planned for surgery, can you usually get the information you need from the biopsy?
A lot, as long as it's a decent size sample, yeah, then yes, and it depends a little bit on how much has been used up in any sort of, if there's any diagnostic uncertainty, or it's quite a small sample that has gone through a lot of histological testing already. But for a lot of patients, we're able to get the information from that initial diagnostic biopsy.
And just last question on this case. So if the patient did have an MMR deficient tumour, would that be sufficient information? If that was the only information you had about the immunological status of the tumour, would you be happy to allowed to prescribe immunotherapy drugs on the basis of that information alone?
So currently we're allowed to prescribe immunotherapy for patients on sort of first line treatment to control cancer, so as sort of palliative treatment. But in somebody with a large primary and multiple liver metastases, yes, you could prescribe. The NHS England criteria will want to know the KRAS and NRAS and BRAF, but they initially, when they brought the rules through, you were meant to have that status at the time you were giving the drug, and we sort of kind of went back to them about that, because it does tend to take longer for the genomics to come back than the MMR. So they've now finessed that, so you can say that the status is unknown, and that the reason they wanted to know is there was some data from the trial I discussed suggesting that patients with KRAS mutations and RAS mutations may get less benefit from immunotherapy than patients with no mutation or BRAF mutation. So that's kind of currently still under investigation, really, and some other studies haven't shown the same impact. But you could get on with immunotherapy without waiting for the RAS and the BRAF testing.
Okay, thank you, Mike. If you could have the next slides, Liam. So I think with the first case, I think all agreed that reflex testing would be reasonable in that case. This is a slightly different case. Again, we've got a young patient, Mike. They've got a bulky right colon cancer. The radiologist and the MDT are pretty happy that these nodes are running along the ileocholic chain, are involved. They're reaching the base of the mesentery, so we're not sure we're going to be able to get surgical clearance. There's no metastatic disease. Is this a different scenario? Should we be again requesting KRAS, NRAS, and BRAF reflexly, or do you think there'd be too great a risk of wasting resource if we don't utilize the result of the genomic test?
So I guess at the moment this patient wouldn't fulfill the NHS criteria, assuming they've got operable disease and everything could be resected. They wouldn't meet the NHS criteria to get RAS and BRAF testing done, because I guess the purpose of doing that testing is to inform whether patients get this EGFR targeted treatment. So at this point, doing the test wouldn't alter the patient's initial management. So we wouldn't normally test this patient. Within trials, so we talked a bit about the Foxtrot study, and there is now a program of a number of different Foxtrot studies which are sort of filling this sort of preoperative treatment space. And the Foxtrot trial is now looking to incorporate genomic testing for these sort of bulky, locally advanced tumours to inform which trials patients go into. So there's a small trial for BRAF mutant patients. There's a planned trial of HER2 targeted treatment as a preoperative treatment. I guess the direction of travel is that more and more this testing will be done earlier. At the moment, this doesn't sort of fit with the current guidelines, but the suspicion would be in 5 to 10 years' time, probably we are going to move to a situation where it is reflexly done on everybody, but we're not there yet.
Thank you. So sure, that's clearly, I agree, that is the direction of travel. Just before we do the last case, we've got a couple of questions. A question about HER2 testing, Mike. Do you think that that's appropriate? And when do you think that might, if it is, when do you think that might start?
So I guess that is one of the next kids on the block, if you like, that we've got our list, and it has been discussed about adding that into the test directory. I know within the Northwest, with our discussions with the GLH, because we've got a trial open where it's giving HER2 targeted treatment as part of first-line treatment. And obviously we need the testing to be able to identify those patients. So we've got an agreement now that the GLH are going to give us HER2 as a component of the RAS-BRAF kind of test panel. So we should be getting that result up front so that we can look to identify those patients. So we're certainly getting that for the Christie patients, and I would suspect that will be something that will roll out nationally, probably, because there is accumulating data to suggest that there are active therapies for these patients.
Thank you. We've got a couple of questions, further questions. Steve McGrath asks, you may well be best answering this question yourself, Steve, is how well do you think pathologists estimate tumour cell content? And there's sort of a follow-on question, which is really whether scientists in the GLH should be trained in tumour assessment, again, basically cell count and necrosis, as we've heard already, whether we think that's, I would have thought that was really more a role for pathology. Anyone feel in a position to comment on Steve's question? What, Steve, are you there? If you're there, what do you think? How well do you think that you do it?
I'm not sure anyone knows how well we're doing. And given that controls whether we use the specimen or not, and in what way we send the specimen to the GLH and what testing they do, it's always a bit of a concern of mine that there's no quality control on it, really. I'm sure the GLH has ways of deciding whether it's a quality sample, but I don't know if they can differentiate between quality normal DNA and quality tumour DNA. So I have noticed that amongst colleagues that we all have different thresholds for what we think represents 20% tumour and what doesn't. So there is an EQA scheme which looks at this, but I'm not sure a lot of people take part when you compare the number of pathologists in the country, and it's still a pilot scheme. So given that so much hangs on these tests, like massive decisions hang on these tests, that's just a little bit of a concern of mine still.
Yes, I think Steve, that emphasises that this is pretty new to everybody, really. and also emphasise the importance of us looking at the pathology side of things, which, as you know, is often not done. I mean, we had a discussion with the GLH, and I'll put this question to them that you've raised. We did ask the GLH. They said you need a fresh slide, and actually we said to them, well, what's fresh? And they said, well, we're not sure, but probably up to 6 months is okay. Which again, I think just emphasises that this is a lot of it is new processing for us, and the more that we understand the questions that you've asked, the better. So I will put that to the GLH, and then we've got somebody with their hand up. Yeah.
Hi, good evening. My name is Paul Simcock. I'm a consultant pathologist at Stoke. Just on that topic, I do wonder whether perhaps digital pathology and then the advent of AI with their algorithms may provide us with a solution to that issue in the future, where they could count nuclei in a much more accurate way than perhaps we could as pathologists.
Yeah, that's a good point, and that may well be the case. I think it's an important question, and I will put it to the GLH, because the sort of language about the greater than 20% is it for a non-pathologist seems fairly straightforward. But I'm interested in your question, Steve, and I will pursue that further, and I will involve you in that if you are interested to do so.
I guess it's kind of worth mentioning, Jim, that I guess if it's below 20%, often the report comes with a caveat about low cellularity. So obviously, if you identify a mutation, then you're happy, but it's just those patients where you don't identify an abnormality and you've got low cellularity. There's that caveat about, well, do you just not have kind of enough cells to have identified a KRAS mutation in that patient? So that's where the concern comes in.
Sure, and there were some discussions that we had with the GLH about microdissection, Steve, but again, I don't know how well that technique is utilised. So that's certainly ground for further discussion, and I will continue that conversation with you if I may. I'm aware of time, so we'll just go on to the very last case.
Thanks, Jim.
Thank you, Steve. And we perhaps discussed MMR. Perhaps have too much discussion this evening, but it is very interesting. It is very challenging, and certainly there are some exciting developments with rectal cancer. So this is our case. Mike, he's a 70-year-old man. He's got a mid-rectal cancer with threatened margins. There's agreement at the MDT that he'll need pre-op downstaging before considering surgery. We haven't always, a lot of MMR is still being done on the resection specimen. Should we insist that all rectal cancer, I think around about 10% of all rectal cancers have got MMR? Should we be insisting that we have MMR on the biopsy specimen so we can consider immunotherapy as a sole or part of downstaging treatment?
I think so. That if you look at things, as I said, I presented it in the presentation, there was some data about immunotherapy. So there was the colon study where 70-ish% of patients had a complete pathological response on their resection, and then there's a smaller rectal study. Now there's just over 20 patients who'd had a particular immunotherapy drug, and all of those patients have had a complete clinical response, and there's now follow-up on most of those patients, I think up to 2 years without recurrence. So none of them have had an operation, none of them have had radiotherapy. And there are a number of trials now coming in to sort of expand that experience and look to see actually for this group of patients, can immunotherapy be the definitive treatment? Obviously it's early days yet, and I guess at the moment the purpose of doing the MMR partly is Lynch, but kind of partly also is to see, well, can we kind of explore that immunotherapy option probably at this stage in a trial, because it's not available as standard of care unless you're in Wales. where the Welsh Government have made it available for patients. But having that piece of information, because it's likely, as I said, that immunotherapy actually for a locally advanced tumour, particularly if it's as advanced as this is described, would have a much better chance of working than any alternative.
Mike, that's very helpful. Glenda, I don't know whether you want to sum up and ask for feedback, but I would like to add my thanks to all the contributors, and I'd like to thank everyone who has joined the webinar, and Barbara and Celine for coordinating everything.
Thank you. Yeah, I'd just like to say, thank you so much for attending the webinar. I really do hope you've enjoyed it. And like we say, this is the first of many to come. We have a feedback that we would like you to complete. The QR is on there. If you don't get an opportunity, I'm sure Barbara will be able to send this round to everyone to complete. And any questions that you might like to ask that you weren't able to do today, then please, email to us and we'll try and get back to you as soon as possible. Big thank you to all the speakers. I think this has been a fabulous webinar, and I hope everybody has an enjoyable evening. Thank you.